What is the primary difference between erythropoiesis and leukapheresis in terms of cellular regulation and physiological response? Answer: erythropoiesis and leukapheresis are both processes responsible for the production of blood cells, but they are regulated differently and serve distinct physiological functions. Erythropoiesis, the production of red blood cell (RBCS), is primarily regulated by erythropoietin-EPO, a hormone produced in the kidneys in response to low oxygen levels, hypoxia. The key function of erythropoiesis is to ensure a sufficient supply of RBCS to meet the body's oxygen transport needs. This process begins with hematopoietic stem cell (HSCS) in the bone marrow, which differentiate into various stages of precursor cells, eventually becoming mature erythrocytes. As RBCS mature, they expel their nucleus and other organelles to maximize hemoglobin content for oxygen transport. In contrast, leukapheresis is the production of white blood cells, which is primarily governed by various cytokines and growth factors such as interleukins, ILs, colony-stimulating factors (CFS) and DMSF, granulocyte macrophage (CSF). Leukapheresis occurs when the immune system detects pathogens or other inflammatory signals. Unlike erythropoiesis, which focuses on the oxygen-carrying capacity of the blood, leukapheresis involves the production of different types of WBCS neutrophils, lymphocytes, monocytes, etc., to fight infections and participate in immune responses. Which hematologic parameters would be most affected in a case of iron deficiency anemia, and what specific changes would you expect in these parameters? Answer: iron deficiency anemia either is characterized by insufficient iron levels, which leads to impaired hemoglobin (HB) production and a reduction in red blood cell (BC) production. Several hematologic parameters are affected in IDA, and they provide insight into the underlying pathology. Hemoglobin (HB) levels will be low in iron deficiency anemia due to a reduced ability to produce hemoglobin, the oxygen-carrying component of RECS. The HB levels cause symptoms such as fatigue, weakness, and pallor. Hematocrit (HET). Hematocrit, which measures the proportion of RBCS in the blood, is typically decreased in IDA. This is a secondary effect of the reduced RBC mass caused by insufficient iron availability. Mean corpuscular volume (MCV). MCV measures the average size of RECS, and in IDA it is typically decreased, reflecting the presence of smaller than normal RECS, known as microcytic anemia. This is due to impaired hemoglobin synthesis, which results in smaller cells. Mean corpuscular hemoglobin (MEH). MCH, which measures the average amount of hemoglobin per RBC, is also reduced in IDA because there is less hemoglobin available. The individual RBCS are pale hypochromic and have a decreased hemoglobin content. Red cell distribution, where RWD is a measure of the variation in RBC size. In IDA, RDW is often increased as the bone marrow produces a mixture of normal-sized and small hypochrome RBCS. This reflects the dynamic nature of RBC production as the body attempts to compensate for the anemia. Reticulocyte count. Reticulocyte count may be low or normal in early IDA as the bone marrow is often unable to produce a large number of RBCS despite iron deficiency. Overall, these hematologic changes, SCV, MCH, and INCREDIDU, are indicative of microcytic hypochromic anemia and are key to diagnosing iron deficiency. The diagnostic workup would typically include serum ferritin iron studies and transferrin saturation to confirm the diagnosis. Mrs. Thompson, a 50-year-old patient, presents with recurrent nosebleeds, easy bruising, and prolonged bleeding after minor cuts. Her lab results show an elevated prothrombin time (PT) and activated partial thromboplastin time (APT), while platelet count is within the normal range. What is the most likely diagnosis, and what could be the underlying cause? Answer: Mrs. Thompson's clinical presentation of recurrent nosebleeds, easy bruising, and prolonged bleeding after minor cuts, combined with elevated PT and APTT, suggests a bleeding disorder related to clotting factor deficiencies. The normal platelet count indicates that the problem is not with platelet function, but rather with the coagulation cascade. Given the prolonged PT and APTT, the most likely diagnosis is an acquired coagulopathy due to liver disease or vitamin K deficiency. Liver disease. The liver is responsible for producing most of the clotting factors, including factors I, VII, IX, and X, all of which are part of the common and extrinsic pathways of the coagulation cascade. In liver disease, such as cirrhosis or hepatitis, production of these factors is impaired, leading to prolonged PT and APTT. The normal platelet count helps rule out primary thrombocytopenia and supports the possibility of a clotting factor deficiency. Additional liver function tests e.g. AST, ALT, bilirubin, and imaging may confirm the diagnosis. Vitamin K deficiency. Vitamin K is essential for the activation of clotting factors I, VI, IX, and X. A deficiency in vitamin K can occur in cases of poor dietary intake, malabsorption, e.g., in patients with celiac disease or those on long-term antibiotics, or liver dysfunction. Vitamin K deficiency typically causes a prolonged PT, as factor VI is most sensitive to a decrease in vitamin K levels. The APTT may also be prolonged if other clotting factors are deficient. Testing for vitamin K levels or a clinical history suggestive of vitamin K deficiency, e.g., recent antibiotic use, would help confirm this diagnosis. In both cases, further diagnostic tests like liver function tests, vitamin K levels, and possibly a coagulation factor assay would be necessary to establish the exact cause of the coagulation abnormality. How do schistocytes and spherocytes differ in terms of morphology and clinical significance on a peripheral blood smear? Answer: schistocytes and spherocytes are both abnormal red blood cell (RBC) morphologies seen on peripheral blood smears, but they differ in their appearance, underlying causes, and clinical significance. Schistocytes. Schistocytes are fragmented RBCs that appear as irregularly shaped pieces, often with sharp edges. They are typically seen in conditions that cause mechanical damage to RBCs as they pass through constricted or abnormal vascular structures. Common causes of schistocyte formation include microangiopathic hemolytic anemias, MAHA, disseminated intravascular coagulation, DIC, thrombotic thrombocytopenic purpura (TTP), and hemolytic uremic syndrome (HUS). These disorders involve the formation of small thrombi or fibrin strands that physically fragment RBCs as they pass through the microvasculature. Schistocytes are a hallmark of these conditions and are indicative of mechanical RBC damage. The presence of schistocytes on a peripheral blood smear usually prompts further investigation into these life-threatening conditions. Spherocytes. Spherocytes are RBCs that are smaller and more spherical than normal RBCs, lacking the central pallor typically seen in healthy RBCs. This morphological change is usually due to a defect in the RBC membrane, which results in a loss of the cell's characteristic biconcave shape. Spherocytes are commonly associated with hereditary spherocytosis, a genetic disorder caused by mutations in proteins that anchor the RBC membrane, such as spectrin or ankyrin. They can also be seen in autoimmune hemolytic anemia (AIA), where antibodies bind to ECS, leading to their destruction by the spleen. In hereditary spherocytosis, these cells are prone to premature destruction in the spleen, leading to hemolysis. The clinical significance of spherocytes lies in their association with chronic hemolysis and splenomegaly. In summary, schistocytes indicate mechanical RBC damage due to conditions like DIC or TTP, while spherocytes are typically seen in membrane defects or immune-mediated hemolysis, such as hereditary spherocytosis or AIHA. Correctly identifying and differentiating these cells is crucial for diagnosing the underlying pathology. Explain the role of reticulocyte count in evaluating anemia and how it can help distinguish between different types of anemia. Answer: the reticulocyte count is an important diagnostic tool for evaluating anemia and distinguishing between different causes of anemia. Reticulocytes are immature red blood cell (RBCs) that are produced in the bone marrow and released into the bloodstream before they fully mature into erythrocytes. The reticulocyte count reflects the bone marrow's response to anemia and can provide insight into the underlying cause. Normal reticulocyte count. In a healthy individual, the reticulocyte count is typically around 0.5–2.5% of the total RBC count. A normal count suggests that the bone marrow is functioning normally and is producing RBCs at an appropriate rate. Elevated reticulocyte count. An elevated reticulocyte count, reticulocytosis, is often seen in hemolytic anemia or acute blood loss. In these conditions, the bone marrow compensates for the rapid loss of RBCs by increasing the production of reticulocytes. In hemolytic anemia, reticulocytosis reflects the marrow's attempt to replace RBCs that are being destroyed prematurely. In acute blood loss, the body's response to blood volume reduction is to increase RBC production, which manifests as an elevated reticulocyte count. A high reticulocyte count indicates that the anemia is regenerative and that the bone marrow is actively producing RBC. Low reticulocyte count. A low or absent reticulocyte count suggests hyperproliferative anemia, where the bone marrow is not producing enough RBCs to compensate for blood loss or destruction. This is commonly seen in iron deficiency anemia, aplastic anemia, or chronic disease anemia, where the marrow's ability to generate RBCs is impaired. In such cases, despite the presence of anemia, the marrow's response is inadequate or delayed, leading to a low reticulocyte count. Reticulocyte count in iron deficiency. In iron deficiency anemia, the reticulocyte count may initially be low, as iron is required for RBC production. However, after iron supplementation is started, the reticulocyte count typically increases as the bone marrow begins to produce RBCS more efficiently. In summary, the reticulocyte count is a valuable tool for assessing the marrow's response to anemia and can help distinguish between regenerative anemias such as hemolytic anemia or acute blood loss and hyperproliferative anemias such as iron deficiency or bone marrow disorders. Explain how the tricarboxylic acid (TCA) cycle integrates with glycolysis and oxidative phosphorylation. Describe the significance of each pathway's metabolites in cellular respiration. Answer: the TCA cycle, glycolysis, and oxidative phosphorylation are key metabolic pathways in cellular respiration, crucial for ATP production. Glycolysis, which occurs in the cytoplasm, begins with glucose and produces pyruvate, generating 2 ATP and 2 NADH molecules in the process. This pyruvate is then transported into the mitochondria where it is converted into acetyl-CoA by the enzyme pyruvate dehydrogenase. Acetyl-CoA enters the TCA cycle, also known as Krebs cycle or citric acid cycle, which occurs in the mitochondrial matrix. The TCA cycle is responsible for producing high-energy molecules. NAD and FAD are transferred through protein complexes in the inner mitochondrial membrane. The electron transport chain generates a proton gradient, which is used by ATP synthase to produce ATP. The TCA cycle also generates intermediate metabolites, such as oxaloacetate and succinate, which play vital roles in maintaining cellular homeostasis, including biosynthesis of amino acids and nucleotides. The final product of oxidative phosphorylation is ATP, which cells use to power various biochemical processes. Disruptions in any of these pathways, such as mutations in enzymes like pyruvate dehydrogenase, can lead to metabolic disorders, including lactic acidosis and mitochondrial diseases, demonstrating the crucial interdependence of these pathways for cellular energy homeostasis. Describe the principle of spectrophotometry and its application in determining serum creatinine levels in clinical chemistry. Answer: spectrophotometry is an analytical technique used to measure the absorbance of light by a sample at a specific wavelength. According to the Beer-Lambert law, absorbance is directly proportional to the concentration of the absorbing substance and the path length of the light. In clinical chemistry, spectrophotometry is widely used for quantifying serum analytes, such as creatinine, by measuring the intensity of light absorbed by the sample. For serum creatinine, the JAF reaction is commonly used, in which creatinine reacts with picric acid in an alkaline solution to form a yellow-orange complex. The intensity of this color is directly proportional to the concentration of creatinine in the sample. The absorbance is measured at a wavelength of 520 nm using a spectrophotometer. Calibration curves, constructed by plotting the absorbance of known concentrations of creatinine, allow for the determination of unknown serum creatinine levels. Accurate measurement is critical as serum creatinine is used to assess renal function, specifically glomerular filtration rate, GFR, which is a key indicator of kidney health. Quality control measures, such as the use of Westgard rules, ensure the reliability and reproducibility of results. Variations in serum creatinine levels can be influenced by factors like muscle mass, diet, and hydration status, so clinicians must interpret the results in the context of patient-specific characteristics. Why is HbAC considered a more reliable marker than fasting glucose for monitoring long-term glycemic control in diabetic patients? Answer: hemoglobin S HbAC is a form of hemoglobin that is non-enzymatically glycosylated, meaning it binds to glucose in the bloodstream. Its formation is directly proportional to the average blood glucose concentration over the lifespan of a red blood cell, which is about 120 days. As a result, HbAC provides a long-term indicator of blood glucose control, reflecting average levels over the past 2-3 months. In contrast, fasting glucose levels measure blood glucose at a single point in time, making it susceptible to fluctuations due to factors such as stress, illness, and time of day. HbAC remains relatively stable over time and is not affected by short-term variations, making it a more reliable marker for monitoring overall glycemic control in patients with diabetes. The American Diabetes Association, ADA, and other health organizations recommend maintaining HbAC levels below 7% for most adults with diabetes to reduce the risk of complications, including cardiovascular disease, neuropathy, and retinopathy. Fasting glucose is still useful for diagnosing diabetes or assessing acute changes in glucose levels, but HbAC is preferred for ongoing monitoring because it reflects the overall effectiveness of a patient's treatment regimen Moreover, conditions such as anemia, hemoglobinopathies, and pregnancy can interfere with H-back measurements, so alternative markers such as fructosamine may be used in such cases. Explain the application of the Westgard multi-rule approach in clinical laboratories and discuss how it enhances quality control. Answer: Westgard rules are a set of statistical quality control rules used to monitor the accuracy and precision of laboratory test results. These rules help identify both random and systematic errors in the testing process, ensuring that test results are reliable and within acceptable limits. The rules are typically applied to control samples that are analyzed alongside patient samples during routine testing. For example, the 1-2's rule signals a potential random error if a single control result exceeds 2 standard deviations (SD) from the mean. The 2-2's rule, which requires 2 consecutive results exceeding 2 SD, indicates a potential systematic error, suggesting that a problem may be developing in the assay system. Other rules, such as the WA4's rule, identify a range of values that are too large, which may indicate a problem with reagent performance or instrument calibration. By applying these rules, laboratories can detect when an assay is malfunctioning and take corrective action before erroneous patient results are reported. The Westgard multi-rule approach enhances quality control by incorporating multiple levels of checks, ensuring that any deviations from expected performance are caught early, preventing false conclusions and improving patient care. Proper training in the use of these rules, along with routine maintenance and calibration of equipment, is essential for maintaining high-quality standards in clinical testing. Dr. Emily Scott suspects drug toxicity in a patient exhibiting symptoms of confusion and drowsiness. The patient is on phenytoin therapy for epilepsy. Serum levels reveal a concentration slightly above the therapeutic range. What should Dr. Scott consider before adjusting the dose? Answer: Phenytoin is a medication with nonlinear pharmacokinetics, meaning that small changes in dose can lead to disproportionately large changes in serum drug levels. This phenomenon is due to the fact that phenytoin is highly protein-bound and metabolized by the liver. If the drug concentration is slightly above the therapeutic range, it can rapidly rise to toxic levels due to saturation of the liver enzymes involved in its metabolism. Dr. Scott must consider several factors before adjusting the dose. First, she should confirm whether the patient's symptoms, confusion and drowsiness, are truly due to phenytoin toxicity, as these can be non-specific and overlap with other conditions such as electrolyte imbalances or infections. Second, she should assess the patient's liver function, as hepatic impairment can slow the metabolism of phenytoin, leading to elevated drug levels. Third, any drug interactions that may inhibit phenytoin metabolism, such as with warfarin or amiodarone, should be evaluated. Given the narrow therapeutic range of phenytoin, careful monitoring is critical and dose adjustments should be made gradually. Dr. Scott may consider reducing the dose or temporarily discontinuing the drug, followed by checking serum levels to avoid overshooting the target range. Finally, Dr. Scott should provide the patient with clear instructions regarding medication adherence, as inconsistent dosing can also lead to toxicity or subtherapeutic levels. What does a pattern of elevated TSH with low T indicate in thyroid function tests, and what might be the cause? Answer: a pattern of elevated TSH with low T levels typically indicates primary hypothyroidism, a condition where the thyroid gland is unable to produce sufficient amounts of thyroid hormones. In primary hypothyroidism, the thyroid gland fails to respond adequately to stimulation from TSH, thyroid-stimulating hormone, leading to low levels of triiodothyronine and T-thyroxine in the blood. The pituitary gland compensates by increasing the production of TSH in an attempt to stimulate the thyroid gland. Common causes of primary hypothyroidism include autoimmune thyroiditis, particularly Hashimoto's disease, in which the immune system attacks the thyroid gland, leading to inflammation and decreased hormone production. Other causes include iodine deficiency, which impairs thyroid hormone synthesis, or thyroid surgery or radiation that reduces thyroid tissue. Symptoms of primary hypothyroidism include fatigue, weight gain, cold intolerance, and constipation, among others. Treatment typically involves thyroid hormone replacement therapy, levothyroxine, to restore normal hormone levels and alleviate symptoms. Regular monitoring of TSH and thyroid hormone levels is necessary to adjust the dosage of levothyroxine and ensure optimal thyroid function. Describe the Michaelis-Menten kinetics of enzyme-catalyzed reactions and how it applies to laboratory enzyme assays. Answer: the Michaelis-Menten equation describes the relationship between the rate of an enzyme-catalyzed reaction and the concentration of substrate. According to this model, the enzyme binds to the substrate to form an enzyme-substrate complex, which then breaks down into product. The rate of the reaction increases as the concentration of the substrate increases, but it eventually reaches a maximum velocity, Vmax, where the enzyme is saturated with substrate and cannot process more. The Michaelis constant kilometers is a measure of the affinity of the enzyme for its substrate. Lower kilometers values indicate higher affinity. In clinical laboratories, enzyme assays often use this principle to measure enzyme activity or concentration. For example, in the case of liver function tests, enzymes like alanine aminotransferase ALT and aspartate aminotransferase AST are measured based on their ability to catalyze the conversion of a specific substrate into product. By varying the concentration of substrate and measuring the reaction rate, laboratory technicians can determine the enzyme's kilometers and Vmax, which are useful for diagnosing conditions that affect enzyme function, such as liver diseases or myocardial infarction. In practice, however, enzyme assays are often run at substrate concentrations that exceed kilometers, ensuring that the reaction rate is linear and can be easily measured, with results used for diagnostic purposes. What is the significance of COHGO in an arterial blood gas-Abab analysis, and how do they relate to acid-base balance? Answer: arterial blood gas-Abab analysis measures the pH, partial pressure of carbon dioxide (PCO) and bicarbonate ion concentration (HEA) to evaluate the acid-base status of the body. The pH measures the hydrogen ion concentration with a normal range of 7.35 to 7.45. A low pH 7.45 indicates alkalosis. The PCO reflects the respiratory component of acid-base balance and is a measure of the amount of carbon dioxide in the blood. Co-combines with water to form carbonic acid, which dissociates into hydrogen ions and bicarbonate, influencing EH. The normal range for ECO is 3,5,4-fibamate, elevate ECO 40-fibamate G suggests respiratory acidosis, while low ECO 30-fibamate G indicates respiratory alkalosis. HCO represents the metabolic component of acid-base balance and is a buffer that helps neutralize acids in the blood. The normal range for HCO is 2,2,2,8 mecol. Elevated bicarbonate levels can indicate metabolic alkalosis, while decreased levels are seen in metabolic acidosis. A BG analysis provides critical information about the cause of acid-base disturbances, helping clinicians diagnose respiratory or metabolic disorders, such as chronic obstructive pulmonary disease (COPD) or diabetic ketoacidosis (DKA), and guide appropriate treatment, such as administering bicarbonate or adjusting ventilation. What is the clinical significance of proteinuria in urine analysis, and how does it indicate kidney damage? Answer: proteinuria, the presence of excess protein in the urine, is a key indicator of kidney damage, particularly in conditions that affect the glomeruli, the filtering units of the kidneys. Under normal conditions, the glomeruli filter blood to remove waste products while retaining larger molecules like proteins. However, in diseases such as glomerulonephritis, diabetic nephropathy, or hypertension, the glomerular filtration barrier is damaged, allowing proteins such as albumin to leak into the urine. Proteinuria can be quantified based on the protein to creatinine ratio in a urine sample with persistent levels above 30 mdL considered abnormal. Proteinuria is one of the earliest signs of kidney dysfunction, and its presence suggests that the kidneys are no longer able to filter properly. In clinical practice, proteinuria is used to monitor kidney function in patients with diabetes, hypertension, and chronic kidney disease (CKD). Early detection and intervention can help slow the progression of kidney damage, and treatment may include controlling blood sugar, blood pressure, or using medications like ACE inhibitors, which help reduce protein leakage. Additionally, a dipstick test or 24-hour urine collection may be used to assess proteinuria, while more advanced methods, such as urinary albumin to creatinine ratio, provide more accurate measurements. Explain the principle of enzyme-linked immunosorbent assay, ELISA, and its application in detecting antibodies. Answer: the enzyme-linked immunosorbent assay, ELISA, is a laboratory technique used to detect and quantify the presence of antibodies or antigens in a sample. It relies on the specific binding between an antigen and its corresponding antibody, which is coupled with an enzyme that produces a measurable signal. In a typical ELISA, the target antigen is immobilized on a solid surface, usually a microplate. The sample containing antibodies is added, and any antibodies that specifically bind to the antigen are retained on the surface. After washing away unbound components, an enzyme-linked secondary antibody, which binds to the primary antibody, is added. The enzyme catalyzes a reaction that produces a color change, which can be measured spectrophotometrically. The intensity of the color is directly proportional to the concentration of the antibody in the sample. The ELISA is highly sensitive and specific, making it widely used in diagnosing infections such as HIV and autoimmune diseases such as rheumatoid arthritis. Variations of ELISA, such as direct-indirect, sandwich, and competitive LISA allow for different applications depending on the type of antigen or antibody being tested. LISA is also employed in research for measuring cytokines, hormones, and other biomarkers, offering a reliable and versatile tool in clinical diagnostics and laboratory testing. What are the differences between the extrinsic and intrinsic pathways of the coagulation cascade, and how are they activated in the body? Answer: a coagulation cascade is a complex series of events that lead to blood clot formation to prevent excessive bleeding following injury. The two main pathways of the coagulation cascade are the extrinsic pathway and the intrinsic pathway, both of which ultimately converge at the common pathway, extrinsic pathway. The extrinsic pathway is the body's first response to blood vessel injury and is activated by external tissue factors. When a blood vessel is damaged, tissue factor TF, also known as factor II, is exposed to the blood. TF binds with factor VII, an active form of factor VII in the blood, to form a complex TFR. This complex activates factor X, the common pathway, which then combines with factor V to form prothrombinase. This enzyme complex activates prothrombin, factoramentor, to thrombin, factor ER, which plays a central role in converting fibrinogen to fibrin, creating the clot. Intrinsic pathway. The intrinsic pathway involves factors that are all present within the bloodstream and is activated when blood comes into contact with negatively charged surfaces, such as exposed collagen at the injury site. The process begins with the activation of factor XI, Hageman factor, upon contact with the surface. Activated factor XI0 then activates factor XI0, which activates factor IX-IXA. Factor IXA in combination with factor VIR activated factor OMNI activates factor XA, leading to the formation of the prothrombinase complex, which then activates prothrombin to thrombin. Common pathway. Both pathways converge at factor X. Once activated, factor X works with factor V to form prothrombinase, which converts prothrombin into thrombin. Thrombin is essential in the formation of a stable fibrin clot by converting fibrinogen into fibrin strands, which mesh together to stabilize the clot. In summary, the extrinsic pathway is triggered by tissue factor exposure following vessel injury, while the intrinsic pathway is activated by contact with negatively charged surfaces. Both pathways lead to the common pathway, which results in thrombin activation and clot formation. What role does the spleen play in the destruction of aged red blood cells, and what are the consequences if the spleen is non-functional? Answer: the spleen plays a critical role in the removal of aged or damaged red blood cell (RBCS) from the circulation, a process known as erythrophagocytosis. As RBCS age, typically after about 120 days in circulation, the cell membranes become less flexible, making them more susceptible to damage and less able to navigate through the microcirculation, especially in small capillaries like those found in the spleen. Role of the spleen: filtration of RBCS. As RBS pass through the spleen, particularly the splenic red pulp, they are filtered out. The spleen's narrow capillaries trap and break down cells that have become rigid, leading to their engulfment by macrophages. Within the spleen, these macrophages phagocytose the RBCS, breaking them down into their component parts, such as hemoglobin, which is further metabolized into bilirubin and excreted via a liver. Iron recycling. The spleen also recycles iron from the breakdown of hemoglobin and returns it to the bloodstream, where it can be reused for the production of new RBCS in the bone marrow. Consequences of non-functional spleen asplenia. Impaired RBC clearance. In the absence of a functional spleen asplenia, aged or damaged RBCS may not be efficiently cleared from the circulation. This can lead to autoimmune hemolytic anemia or splenic sequestration, where dysfunctional RBCS remain in circulation longer than normal. Increased risk of infection. The spleen is also an important organ in filtering out bacteria, particularly encapsulated bacteria like Streptococcus pneumoniae and Haemophilus influenzae. Without a spleen, the body's ability to clear these infections is diminished, leading to an increased risk of severe infections. Asplenic individuals may be more susceptible to sepsis, particularly after trauma or splenectomy. Development of Howell-Jolly bodies. In patients with a non-functional spleen, small nuclear remnants known as Howell-Jolly bodies can be seen in the RBCS peripheral blood smear. These bodies are usually removed by the spleen but remain when the spleen is absent or non-functional. What is the significance of a peripheral blood smear in diagnosing anemia, and what findings would suggest? A microcytic versus a macrocytic anemia. Answer: a peripheral blood smear is an essential diagnostic tool for evaluating the morphology of red blood cell (RBCS), which helps in the identification and classification of anemia. By examining the size, shape, and color of RBCS, clinicians can identify key features that suggest specific types of anemia. Microcytic anemia. Microcytic anemia is characterized by smaller than normal RBCS and is usually indicated by a decreased mean corpuscular volume in CV on the complete blood current (CBC). The findings on a peripheral blood smear that are suggestive of microcytic anemia include smaller RECS. The RBES appear smaller than normal, often with an increased central pallor, a lighter area in the center of the cell. Hypochromia. In microcytic anemia, the RBCS are often hypochromic, meaning they have less hemoglobin, leading to pale or light-colored cells. This is most commonly seen in iron deficiency anemia. Target cells. Some types of microcytic anemia, particularly in conditions like thalassemia, may show target cell RBCS with the bullseye appearance. Macrocytic anemia. Macrocytic anemia, in contrast, is characterized by larger than normal RBCS and is associated with an increased MCV on a peripheral blood smear. Signs of macrocytic anemia include larger RBCS. The RBCS are noticeably larger than normal, and the central pallor may be reduced or absent. Ovulocytes. In conditions like vitamin B deficiency or folate deficiency, the RBCS may appear oval-shaped rather than the typical round shape. Hypersegmented neutrophils. A key finding in megaloblastic anemia, a type of macrocytic anemia especially due to vitamin B or folate deficiency, is the presence of hypersegmented neutrophils with more than 5 nuclear lobes. The peripheral blood smear, along with CBC results, helps to identify whether the anemia is microcytic. Small ECS, typically seen in iron deficiency anemia, or macrocytic, larger ECS, often seen in vitamin B or folate deficiency. Identifying these morphological changes can guide further diagnostic tests to determine the underlying cause of anemia. How do hemoglobinopathies like sickle cell disease and thalassemia differ in terms of pathophysiology, clinical presentation, and diagnostic findings? Answer: hemoglobinopathies such as sickle cell disease (SCD) and thalassemia are inherited disorders that affect the structure and production of hemoglobin, leading to various hematological and clinical issues. Sickle cell disease (SCD). Pathophysiology. SCD is caused by a point mutation in the beta-globin gene, leading to the substitution of valine for glutamic acid at the 6th position of the hemoglobin molecule HbS. Under low oxygen conditions, HbS polymerizes and forms rigid structures that distort RBCS into a sickle shape. These sickled cells are less flexible, leading to blockages in small blood vessels and hemolysis, destruction of RBCS. Clinical presentation. SCD is typically characterized by painful crises, anemia, fatigue, increased risk of infections, and possible organ damage due to vaso-occlusion. Patients may also experience splenomegaly and stroke in severe cases. Diagnostic findings. A peripheral blood smear often shows sickle-shaped RBCS and Howell Jolly bodies. Due to splenic dysfunction, hemoglobin electrophoresis confirms the presence of HbS. Additional tests like hemoglobin F levels can help assess the severity of the disease. Thalassemia. Pathophysiology. Thalassemia is a genetic disorder characterized by reduced or absent production of either alpha-globin or beta-globin chains, leading to an imbalance in the hemoglobin tetramer and ineffective RBC production. In alpha-thalassemia, there is a deletion or mutation in one or more of the alpha-globin genes, while in beta-thalassemia, there is a mutation in the beta-globin gene, leading to a decreased production of beta-globin chains. Clinical presentation. The severity of thalassemia depends on the number of mutated genes. Beta thalassemia major Cooley's anemia presents with severe anemia, jaundice, and splenomegaly. In alpha thalassemia, the disease can range from mild anemia with 1 mutation to severe anemia with all 4 mutations. Diagnostic findings. A peripheral blood smear shows microcytic hypochromic RBCS with varying degrees of anisocytosis and poikilocytosis. In beta thalassemia, target cells and basophilic stippling may be seen. Hemoglobin electrophoresis shows elevated levels of HbF or HbA depending on the type of thalassemia. The diagnosis is confirmed by genetic testing. What are the key differences between acute and chronic leukemias in terms of their clinical features, diagnostic findings, and prognosis? Answer: leukemia is a cancer of the blood and bone marrow characterized by uncontrolled proliferation of abnormal white blood cells. There are 2 primary types of leukemia: acute and chronic. The key differences between them lie in their onset, progression, clinical features, and response to treatment. Acute leukemia. Clinical features. Acute leukemia develops rapidly and often presents with fatigue, fever, easy bruising, pallor, frequent infections, and bone pain. This is due to the rapid accumulation of immature white blood cells, blasts in the bone marrow, which impairs normal blood cell production. Diagnostic findings. In acute leukemia, a bone marrow biopsy shows an increased number of blasts, immature leukocytes, usually greater than 20% of the total cells. The peripheral blood smear may show blasts, which are large cells with immature features. Prognosis. The prognosis of acute leukemia depends on several factors, including the specific type, age, and response to chemotherapy. AML and ALL are aggressive, with poor prognosis if untreated, but aggressive chemotherapy can achieve remission. Chronic leukemia. Clinical features. Chronic leukemia develops more slowly and is often asymptomatic in the early stages. When symptoms do appear, they are more gradual and include fatigue, weight loss, spleen or liver enlargement, splenomegaly, hepatomegaly, and low-grade fever. These symptoms occur because the abnormal leukocytes accumulate over time. Diagnostic findings. In chronic leukemia, the bone marrow contains a large number of mature but abnormal white blood cells. The peripheral blood smear shows elevated white blood cell count with mature leukocytes and possibly blasts in later stages. Chronic leukemias include chronic myelogenous leukemia (CML) and chronic lymphocytic leukemia (CLL). Cytogenetic tests such as the Philadelphia chromosome in CML help in diagnosis. Prognosis. Chronic leukemias have a much slower progression compared to acute leukemias. In some cases, such as CLL, the disease can remain indolent for many years with minimal symptoms. Treatment with targeted therapies and chemotherapy can improve prognosis significantly, but chronic leukemias are generally considered incurable in the long term. Explain the significance of Gram staining in classifying bacteria and how the results correlate with the bacterial cell wall structure. Discuss how this method assists in the identification and treatment of bacterial infections. Answer. Gram staining is a crucial method for classifying bacteria into two major categories, gram-positive and gram-negative. This classification is based on the composition of the bacterial cell wall. Gram-positive bacteria have a thick peptidoglycan layer in their cell wall, which retains the crystal violet stain appearing purple under the microscope. Examples include Staphylococcus aureus and Streptococcus pneumoniae. Gram-negative bacteria have a thinner peptidoglycan layer but possess an outer membrane containing lipopolysaccharides or PS, which does not retain the crystal violet stain but instead takes up the counterstain safranin appearing pink. Examples include Escherichia coli and Pseudomonas aeruginosa. Gram staining not only helps in classification but also informs treatment. For instance, gram-negative bacteria often require different antibiotics, e.g. aminoglycosides, due to their outer membrane that limits antibiotic penetration, whereas gram-positive bacteria are more susceptible to cell wall targeting antibiotics like penicillin. Discuss the importance of PCR in detecting HIV infections. How does PCR differ from traditional serologic methods, and what are the advantages and disadvantages of using PCR in the diagnosis of HIV? Answer. Polymerase chain reaction (PCR) is a molecular diagnostic technique that amplifies small amounts of HIV RNA or DNA in the patient's blood. PCR can detect HIV infections much earlier than serologic methods, such as the LISA or Western blot, because it detects the virus directly rather than waiting for the body's immune response antibody production. Advantages of PCR. Early detection. PCR can detect the virus before the immune system produces detectable antibodies, which is especially useful during the acute phase of infection. Quantification. PCR can quantify the viral load, providing essential information about the progression of the infection and the effectiveness of antiretroviral therapy. Disadvantages of PCR. Cost and complexity. PCR testing is more expensive and requires specialized equipment and trained personnel. False positives. PCR may sometimes give false positives if the sample is contaminated. Relevant guidelines. The CDC, Centers for Disease Control and Prevention, and WHO, World Health Organization, recommend PCR as part of the early detection protocol for HIV in high-risk individuals or newborns exposed to HIV. Describe the laboratory techniques used for the identification of Candida albicans in clinical specimens. What are the advantages of using a direct microscopic examination versus fungal culture? Answer. Identification of Candida albicans, a common fungal pathogen, typically involves multiple laboratory techniques. Direct microscopic examination, a rapid method involving the use of KOH preparation or gram staining to visualize fungal cells in clinical specimens, e.g. swab sputum. Candida cells appear as budding yeast with pseudoephy. Fungal culture. This method involves growing the pathogen on Sabouraud dextrose agar or chrome agar, which allows identification based on colony morphology, cream-colored colonies, and biochemical tests, e.g. carbohydrate assimilation tests. PCR and serologic testing. PCR is becoming a popular method for detecting Candida due to its high sensitivity. Serologic testing for antibodies or antigens may also assist in identifying systemic infections. Advantages of direct microscopic examination. Speed. provides almost immediate results, especially when urgent diagnosis is needed, cost-effective, less expensive than culturing and testing. Advantages of fungal culture: higher sensitivity and specificity. Cultures allow for more accurate identification and species differentiation. Antibiotic susceptibility testing. Cultures can be used to perform antifungal susceptibility tests, which guide treatment decisions. Irrelevant guidelines. The American Society for Microbiology (ASM) provides guidelines on the diagnosis of fungal infections, including the use of both direct examination and culture methods. Mr. Thompson is a healthcare worker in a busy hospital. He is assigned to collect a stool sample from a patient suspected of having gastrointestinal parasitic infection. Describe the correct procedure for collecting and storing this specimen to ensure accurate laboratory results. Answer: to ensure accurate results and prevent contamination, Mr. Thompson should follow these steps. Patient preparation. Ensure the patient has not taken antiparasitic medications, as they may interfere with the detection of parasites. Specimen collection. Use a clean, leak-proof container for the stool sample. Collect at least 3 separate samples over consecutive days, as parasites may not be excreted consistently. Avoid contaminating the sample with urine or water, as this may hinder the identification of parasites. Transportation. Transport the sample to the laboratory as quickly as possible, ideally within 30 minutes to 1 hour, to preserve any ova or parasites. If immediate transport is not possible, store the sample in a refrigerator to slow down the decomposition of the sample. Storage in the laboratory. If the specimen cannot be examined immediately, store it in formalin or a preservative solution like PVA, polyvinyl alcohol, to preserve the parasite structures. Relevant guidelines. The Centers for Disease Control and Prevention (CDC) and World Health Organization, who provide extensive guidelines on specimen collection and storage for parasitological testing, emphasizing the importance of proper handling to avoid diagnostic errors. Explain how PCR can be used to detect multiple pathogens simultaneously in a clinical sample. What is the advantage of multiplex PCR over traditional PCR? Answer: multiplex PCR is a variation of traditional PCR that allows the simultaneous amplification of multiple DNA targets in a single reaction. This is achieved by designing primers for different pathogens within the same sample. For example, a multiplex PCR assay could detect Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis in respiratory samples from a patient with pneumonia. Advantages of multiple PCR: speed and efficiency. Enables the detection of multiple pathogens in a single test, reducing turnaround time compared to performing separate PCR tests for each pathogen. Cost-effective. Multiplex PCR saves both time and resources since multiple pathogens are detected in a single assay. High sensitivity and specificity. Multiplex PCR provides highly sensitive and specific results with minimal risk of contamination when performed correctly. Relevant guidelines. The Clinical and Laboratory Standards Institute (CLSI) provides guidelines for the use of PCR in pathogen detection, including multiplex PCR assays, ensuring accuracy and reliability in clinical diagnostics. How do stool and blood examinations differ in the detection of Plasmodium species, and why is blood examination considered the gold standard for diagnosing malaria? Answer: stool examination, not typically used for detecting Plasmodium species, as these parasites infect red blood cells, not the gastrointestinal tract. Stool examination is primarily used for identifying intestinal parasites like Giardia or Entamoeba histolytica. Blood examination. The gold standard for diagnosing malaria involves a blood smear where Plasmodium parasites are observed within the red blood cells. Thin and thick smears allow for species identification and quantification of parasitemia, respectively, where blood examination is the gold standard. Blood smears are highly sensitive and can detect low levels of parasitemia, which is crucial for accurate diagnosis and treatment. Blood examination also helps differentiate Plasmodium species, which is vital for determining the appropriate treatment regimen. Relevant guidelines. The World Health Organization, who provides guidelines for malaria diagnosis, emphasizing blood examination and the need for rapid diagnostic tests (RETS) in resource-limited settings. Describe the appropriate biosafety protocols for handling specimens suspected of containing Mycobacterium tuberculosis in a clinical laboratory. Answer: handling specimens containing Mycobacterium tuberculosis (TB) requires strict biosafety measures to prevent the spread of this airborne pathogen. Personal protective equipment (PPE). Lab personnel must wear N respirators. gloves, lab coats, and face shields to protect against aerosolized particles. Biosafety cabinets. Work with TB specimens should always be done inside a certified Class A biosafety cabinet to contain airborne contaminants. Specimen handling. Use appropriate sterilization techniques for decontaminating materials that come into contact with TB samples, including autoclaving or using disinfectants that are effective against mycobacteria. Airflow management. Laboratories should be equipped with negative pressure systems to ensure that air flows into the room and not out of it, preventing contamination of adjacent areas. Relevant guidelines. The CDC and WHO have comprehensive guidelines on laboratory biosafety concerning TB, including the use of personal protective equipment, PPE, and containment measures to ensure the safety of laboratory workers and prevent the spread of infection. What is the principle behind the disk diffusion method for antibiotic susceptibility testing, and how do you interpret the zone of inhibition? Answer. The disk diffusion method, also known as the Kirby-Bow test, involves placing antibiotic-impregnated paper discs on an agar plate inoculated with the bacterial pathogen. The antibiotic diffuses from the disc into the surrounding agar, and a zone of inhibition forms where the antibiotic effectively prevents bacterial growth. Interpreting the zone of inhibition. The size of the zone is measured and compared to standardized charts to determine whether the organism is resistant, intermediate, or susceptible to the antibiotic. A larger zone indicates that the bacteria are more susceptible to the antibiotic, while a smaller zone or no zone indicates resistance. Relevant guidelines. The Clinical and Laboratory Standards Institute (CLSI) provides standardized methods and interpretations for the disk diffusion test, including breakpoints for resistance, intermediate, and susceptible classifications. Mr. Kato is a microbiologist working in a clinical laboratory. He is tasked with identifying an unknown gram-negative bacterium. He performs a series of biochemical tests, and the results show a positive result for catalase indole and urease. Based on these findings, which pathogens should be considered in the differential diagnosis? Answer. Given the positive results for catalase indole and urease, the pathogen could be from the genera Proteus, Klebsiella, or Escherichia e.g. Escherichia coli. Catalase positive indicates the organism produces catalase, an enzyme that breaks down hydrogen peroxide. Indole positive suggests the organism can degrade tryptophan to indole, which is characteristic of Escherichia and Proteus species. Urease positive indicates that the organism produces urease, which hydrolyzes urea to ammonia, creating an alkaline environment. This is commonly seen in Proteus species and Klebsiella species. Further tests, such as the oxidase test, would help to narrow down the differential diagnosis. Relevant guidelines. The American Society for Microbiology (ASM) provides detailed procedures and interpretations for biochemical tests used in bacterial identification, aiding in the proper identification of pathogens based on their metabolic properties. How does nucleic acid hybridization work in pathogen detection, and why is it considered an important tool in molecular diagnostics? Answer. Nucleic acid hybridization is a technique that uses complementary base pairing between a probe, short DNA or RNA sequence, and the target nucleic acid from the pathogen. The probe is labeled with a detectable marker, radioactive or fluorescent, allowing the identification of the pathogen when hybridization occurs. Importance in molecular diagnostics. High specificity. The probe is designed to bind only to a specific DNA or RNA sequence, providing a highly accurate method for pathogen detection. Versatility. Can be used to detect a wide range of pathogens, including bacteria, viruses, and fungi, by using specific probes for different pathogens. Rapid results. Provides faster results than traditional culture methods, which is critical for the timely treatment of infectious diseases. Relevant guidelines. The Clinical and Laboratory Standards Institute (CLSI) provides guidelines for the use of nucleic acid hybridization in clinical diagnostics, emphasizing accuracy, sensitivity, and reliability in pathogen detection.